Unfortunately,
Okay, well, many of us sometimes we have a problem with any of our patients. Uh, Despite our technical abilities and our knowledge, sometimes we fail to relieve pain, or sometimes after a blockade, the patient gets more pain. A failed, a failed intervention is when an optimal performed interventional technique fails to relieve pain or produce worsening of pain in the absence of a major complication after a complete and accurate diagnostic exercise. We are trying to define if is or not a syndrome. A syndrome is a word that comes from the Greek word from concurrence, and it's defined as a set of medical signs and symptoms that are correlated with each other and often with a specific disease. A syndrome is recognized by the recurrent pattern of findings. Uh, the recurrent findings when an interventional pain management fails are psychological factors, wrong expectations, nocebo response, and lack of empathy. The worsening of pain and the no relief of pain is not mentioned by many reviews of complications in interventional pain management. When you look after this, you just find the transient neuritis and the transient sciatic that Dr. Chan mentioned. The worsening of pain, of the no relief of pain, must be included always in the informed consent. Do you include this topic or this possibility in your informed consent? That's correct? Okay. Uh, the ASA closed claims projects in review from Fitzgibbon, he found that the increased pain or no relief of pain was involved in 8% of all the medical suits against interventional pain practitioners. But the question is, if we cannot relieve the pain with our interventions, are we doing a malpractice? Malpractice refers to negligence or misconduct by a professional person. It's the failure to meet a standard of care or a standard of conduct that is recognized by a profession and reaches the level of malpractice when a client or a patient is injured or damaged because error. Negligence is simply the breach in the standard of care. The existence of negligence is based on the following premises. The physician-patient relationship contemplates the existence of a duty. There has been neglect of such duty regarding to the level of care. And the physical or mental damage, morbidity, or mortality has affected the mentioned patient. And the damage is directly related to the referred negligent action or inaction. Any negligent claim compromise a deviation from the standard of care and the quality of this care. Not all complications give rise to legal claims. The main factor triggering the claim is the occurrence of the patient complication or damage. But the tendency to a greater accreditation based on the guidance of international societies like the World International Pain Society is one of the factors that contribute to lessen the incidence of complications. The first thing that a lawyer are going to ask in a process like this, for malpractice, is if is there any indication for the procedure. If there is not an indication for the procedure, they assume that the standard of care was breached. And when you said in a very clear way the indication for the procedure, undocumented, generally this refutes that argument. We are committed to do good practice in pain management. First, we must have a current diagnosis. The patient selection is pivotal for achieving long-term efficacy and positive outcome measure. And we must identify the risk factors associated with infection, medication side effects, vascular or neurologic damage, concomitant pain disease, and we have to fair informed consent is essential before any procedure is undertaken. The informed consent has two very important parts. The patient comes voluntarily and he is well informed and he participates in the decision-making process. Must be signed free, conscious, and voluntary. Must be written and documented, and always must be witnessed. Legal consent can be taken orally, but it violates all the legal safety. To reduce the risks of the adverse event, we must have the right diagnosis, the right equipment, the right site, the right physician, the right assistant, the right image guidance, and the right time, and always the right patient. The preventive strategies to reduce death risk has been magistrally exposed by the previous two lecturers, so I'm not going to talk about that. But why an intervention can fail? My question is, are our procedures enough effective? Are performed in a substandard fashion, or the patient has this media dose? Are the procedures based in good quality evidence, or the psychological factor of the patient are the predominant in these bad results? Or are the patient coming to the doctor with the right expectation? Or are we or not generating good empathy or placebo effect in our patients? The first point, are our interventions not effective? Can be responded this way. Our interpretation of procedure results is different from the patient's ones, third-party payers, and colleagues. Other specialists perceive the procedures less effective than we do. For example, for epidural steroid injections, the most wide practiced procedure, clinical trials performed by interventionists are nearly 3 times more likely to yield positive results than those performed by not interventional physicians. For evidence-based and systematic reviews on steroid epidural injections, the conclusion reached by authors who are interventionists are more than 3 times likely to be favorable than those done by no interventionalist. The basis for this discrepancy is there is a confirmation bias. We tend to public what we think is correct and is according to our way of thinking. The design of clinical trials in pain is poor, and there is a publication bias. We tend to publish just positive results. If you get any review of pain, more than 85% of the results are positives. And there is a huge difference between the clinical trials and our routine care. The data accuracy is not the best, and there are irreconcilable outcomes. In general, all the publicated trials in pain have to be very strict in the selection of patients, and these do not reflect our daily practice. We have to deal in our daily practice with patients that are receiving opioids, that get multiple interventions, that has been in legal problems and legal trials against physicians, or looking for work compensation. And these do not reflect the reality of the practice.
Dr. Christian, can you come to the conclusion?
Yes, sir. Well, the message I want to say is that it's important to recognize that physicians can make errors while practicing within the standard of care. We are not required to practice entirely error-free. What is required is what we do whatever we can to minimize the risks of these errors and their negative effect on our patients. This is accomplished by ensuring what we are well trained and up to date in our medical knowledge. However, this is not enough to prevent malpractice suits when bad outcomes occur. We must also ensure that documentation exists to support our care of the patient, and we have demonstrated our competence, honesty, concern, and empathy for our patients.
Thank you very much. What came out that patient may develop post-procedural syndromes, and what is more important that we are taking the consent for different complications. So the list should also include that the syndromes may occur. Number one. Number two, what he very categorically said that if consent is proper, that it gives you a sort of prevention to be pulled in the court, and that the consent should be very comprehensive, that detailing every aspect, not only the legal but also the individual and the patient's individual beliefs. He also mentioned very categorically that what happens, that what we do, we try our best and we set our own targets, but also look for what patient is thinking. When there is no gap, the problems are less. But what we project and what patient perceives, if the gap is large, possibly the patient can complain and then you may face the suit in the court. Thank you very much. I think with that we come to the end of this session, and we again proceed for the more interesting, more interactive session, that is the panel discussion. We have two great panelists among us, and I take privilege to introduce them. The first is Dr. Sameer Gupta, which brief introduction he has already given. He has a fellowship in anesthesia as well as in the pain. He is a consultant in anesthesia and pain management in the Sheffield Teaching Hospital NHS Trust. He is an honorary lecturer in University of Sheffield. He has chaired and organizer of South Yorkshire Pain Group. He has a very long list of his achievements, but because I will keep reading and they will not be fulfilling or will not be telling everything about him. He has published nationally, internationally. His main interest, which actually I could capture, which impressed me, that he is very much interested in the complex regional pain syndromes and the opioid management. And I think we will ask his experiences and we can share. Our second panelist is from the Steel City, from Jamshedpur, the area which I belong, Dr. Srividya. She is basically anesthesiologist and quite busy in the pain practice because she has a lot of patients. She is a big hospital, 1,000-bedded hospital. She is MD from Cuttack, Odisha. Then she has done the international fellowship from Daradia. She is in current position specialist in the Department of Anesthesia.